So our next talk is given by Dr. Hu from Peking University. So Dr. Hu's presentation is about identification and estimation of treatment effects on the long-term outcomes in the clinical trials with external observational data. Let's welcome Dr. Hu.
It's my pleasure to present my recent work in this conference. I'm Wenjie Hu from Peking University, and I'm a final year PhD student. And today I will talk about identification and estimation of treatment effects on long-term outcomes in clinical trials with external observational data. And this is the joint work with my advisor, Professor Xiaohua Zhou and Professor Peng Wu. This is an overview of my talk. And so in biomedical researches, randomized clinical trials are the gold standard for drug or therapy evaluation. However, the high cost often restricts the sample size and the duration of the randomized clinical trial, especially for chronic diseases. The outcome of interest Y is hard to observe within the period of the randomized clinical trial. As a motivating example, we consider a clinical study on the IgAN disease, which is the most prevalent form of primary glomerular disease worldwide. And a double-blind randomized clinical trial is conducted at Peking University First Hospital for 6 months to compare a new therapy with a standard therapy for IgAN disease. And the outcome of interest is whether the patient will develop renal failure over a period of time. But this disease is a chronic disease, and the long-term outcome is not observed within the 6 months experiment period. So instead, the researcher collected the percentage change in the proteinuria as a surrogate, and then they perform analysis on this surrogate. Actually, and this is a common practice in medical researches for such problems. The researchers often choose a short-term surrogate that is strongly predictive of the outcome and can be observed during the RCT, and then report analysis results for the surrogate. And the criteria of choosing the short-term surrogate has been studied over the years. For example, the Prentice, Frangakis, and Rubin, and also papers by Professor Geng Zhi. But when using surrogates, there are occasions that, for example, the treatment has positive effects on the surrogate, but have a negative effect on the long-term outcome we are interested in. So to avoid this kind of surrogate paradox, stringent unverifiable assumptions must be employed. But fortunately, a few years after the new therapy is approved, the hospitals usually have a large amount of observational data that contains the long-term outcome. So we want to use it to make better inference for the long-term effect. But for the observational data, the existence of the unmeasured confounders will make it difficult to perform valid inference. So we want to combine the RCT data and the observational data to make inference about the long-term treatment effect in the RCT data. And this quantity is of interest for the regulators who want to re-evaluate the effect of a drug or therapy after it is approved. Next, this is some related literatures. Susan acid is considered identifying the long-term causal effect in the RCT data, similar to our setting, but their long-term outcome is not observed in the RCT data, and they assume that the treatment variable is missing in the observational data. But in our setting, we can observe the treatment variable in the observational data. And so our identification condition is weaker than theirs. And Kellos and Mao, they considered the efficiency gain of estimating the causal effect on the long-term outcome by using an observed short-term surrogate when the long-term outcome is missing at random. But however, in their setting, they consider the data comes from only one population. and the parameter of interest in their paper is the average treatment effect in this population. However, in our setting, our data consists of two data sources, the RCT data and the observational data, and the population may be different. And several works have considered a causal parameter similar to ours. They consider the long-term causal effects in the observational data. This is another paper of Susan S. They propose latent unconfoundedness assumption to identify it. And Chen and Rees-Waller gives the semi-parametric bound for this long-term causal effect in observational data under this assumption. And Gassami, they propose two new methods to obtain the identifiability, which relies on two different assumptions. And in Invens, they consider using multiple surrogates that have a sequential structure to identify it. So in comparison, our parameter of interest is different from the full paper, and our identification assumption is weaker than the latent unconfoundedness assumption. Now, let's introduce some notations. We use T to denote the binary treatment, and X is the observed covariates. Y is the long-term outcome we are interested in. And S is the short-term surrogate for the long-term outcome Y. So under the potential outcome framework, we assume the existence of the potential outcomes S1 and Y1, S0, Y0. And G is the indicator for the data source. So G equals 1 means that the data comes from the RCT, and G equals 0 means the data comes from the observational data. So the data we have is that in RCT data, we can observe the treatment covariates and the surrogate with N1 samples. And in the observational data, we can observe the treatment covariates, surrogate, and the long-term outcome. So in the Susan S.'s first paper, they assume that in observational data, the treatment is not observed. Okay. So the parameter of interest, tau, is the average treatment effect in the RCT data. Then we gave our identification conditions for tau. So first, we assume the internal validity of the RCT data. It means that in the RCT data, the treatment assignment is independent of the potential outcome given the covariates, observed covariates X. And assumption 2 is the strict overlap assumption. And this is common in causal inference and missing data literature. So the assumption 3, the mean exchangeability is the key assumption that enable us to identify tau. It means that the conditional mean of YT given the covariates ST and the treatment is the same across the RCT data and the observational data. We write this assumption in using the potential outcome language. And because the consistency assumption requires that S equals ST and Y equals YT. So assumption 3 can be written as this equation, which only consists of the observed outcome. And this mean exchangeability assumption, in fact, is weaker version of the conditional independence assumption, which is brought up by Kellis and Mao. And also, this assumption is weaker than the latent unconfoundedness assumption brought up by Susan S. And this is a causal DAG model that can satisfy our assumption 3. Here, we should notice that the unmeasured confounder U can affect the treatment assignment T and the surrogate S in observational data. but the unmeasured confounder cannot directly affect the y in the observational data. And in fact, if there is a direct edge from U to Y, I think the assumption 3 is usually is not satisfied. So maybe there will be other methods or new methods need to be developed to solve this kind of situation. Okay, then under assumption 1, 2, and 3, we can have the identification results. Yeah, so the proof is not very difficult. So after identification, we want to first give the semi-parametric bound for tau. So the following is some intermediate quantities that will appear in the efficient inference function. The first is the selection propensity score. It means the probability of selection into the RCT group given the surrogate, covariates, and the treatment. And the second is the treatment propensity score for the RCT data. So the EX is usually known for some randomized clinical trial. And then is the regression functions. Notice that there are two regression functions, mu-t(sx) and mu-tx. And these two regression functions, they are not variational independent. So we will talk about that later. Then theorem 1 gives the efficient inference function for tau, and also the semi-parametric efficiency bound for tau in our model. And in addition, the efficiency bound remains the same, no matter whether the propensity score EX is known or not. So after getting the efficient inference function, we can use the parametric working models to calculate the nuisance function and then get the estimator for tau. So concretely, we can use the generalized linear models for the nuisance parameter in phi, including the regression functions and the propensity score functions. And the double robust estimators is given by the following. And we call it double robust is because in theorem 2, we prove that if either 1 or 2 is satisfied, and the estimator is consistent and asymptotically normal. And in addition, this estimator is locally efficient. It will attain the semi-parametric bound when all the working models are correctly specified. But however, this looks very nice if we can correctly specify all the working models. But in fact, it is hard because in the efficient inference function, we can see that some nuisance parameters, like the two regression functions, they are not variationally independent. So when you use some working model, it is difficult to correctly specify both of them. For example, if y is binary, and we use a logistic model for mu-tx, then a logistic model for mu-tx is hard to satisfy. So as a complement, we propose another estimator called the inverse probability weighted estimator that can consistently estimate tau by merely imposing a model for the regression model and the only in the regression model. Yeah, so the idea is that we can see that we can first impute, we can take this term as imputed y for the in the RCT data, and then we use IPW estimator to estimate the long-term causal effect in the RCT data. So clearly, the IPW estimator has much simpler form than the double robust estimator, and thus is more tractable. And also, to improve the efficiency of the IPW estimator, we can also use an estimated propensity score to get the another estimator. And we also proved the asymptotic properties for the IPW estimator. And we can see from equation 4 and 5 that using the estimated propensity score, if the propensity score model is correctly specified, then if we're using the estimated propensity score, the asymptotic variance is smaller than using the true propensity score. This resembles the classical result of Inben's paper, and that using the estimated propensity score can, in fact, increase the efficiency. And then we conduct extensive simulations to assess the finite sample performance of our proposed methods. Because in real data analysis, the sample size of the RCT data is not very large. So in the simulation, we also use a quite small sample size for the RCT data and a larger sample size for the observational data. And I will skip the settings and the simulation results. Let's go to the real data analysis. So the RCT data, as we mentioned before, comes from a double-blind randomized clinical trial consisting of 60 observations. And this is a completely randomized control trial. So with 30 patients assigned to the new therapy and the rest assigned to a standard therapy. And the observation data contains 547 observations, and with 91 patients accept the new therapy. And the outcome of interest Y is a binary variable indicating whether a patient developed a renal failure within 3 or 4 or 5 years. And in this analysis, we consider 2 endpoint criteria for the outcome Y. Endpoint 1 means that the glomerular filtration rate decreased by 30, 40, or 50% from the baseline. And endpoint 2 is indicator whether the GFR is less than 15 in this amount. And the surrogate S is chosen as the percentage change in the proteinuria between the baseline and 6 months. Because the RCT data only conduct for 6 months. So we choose surrogate S as this. And this is our analysis results. So the 3, 4, and 5 means we choose a 3-year or 4-year or 5 years period. And the proportion means that for the endpoint 1, we choose the decreased proportion as 30%, 40%, or 50%. And we can see that the first 3 methods is our method, and the last one is the succinylase method, which is not very reliable for this analysis. So we mainly focus on the first 3 methods. And the p-value is the two-study test for the hypothesis test that the treatment effect is 0 against the treatment effect is not 0. And we can see that the IPW method and the double robust method have similar point estimates, but they have different standard errors. And the point estimates of tau are smaller than 0, indicating that the potential benefit of the new therapy against the standard therapy. And the p-value is, in most cases, they are smaller than 0.05. And besides, with the n time increasing from 3 years to 5 years, the absolute value of the point estimate of tau becomes larger, which indicates that the efficacy of the new therapy against the standard therapy amplifies over time. As a conclusion, in this paper, we gave new identification results and estimation methods for the long-term causal effect in RCT data, which is a very important issue in medical studies. And our identification conditions are weaker than the former literature. And we provide the asymptotic properties of our proposed estimators. And for future directions, I think it would be interesting to explore the theoretical properties of the proposed estimator when all the nuisance parameters are estimated with the machine learning methods. And also when the observed covariance is high dimensional. And one possible extension is to consider how to obtain valid confidence interval of our proposed estimators when either the propensity score model or the outcome model is correctly specified. Okay, and then this is some references, and thank you for listening, and welcome. If you have any questions, welcome. Thank you.
Thanks, Wenjie, for the nice talk. I think we still have some time for questions. Yeah, if you have questions, but you are probably shy to speak, you can type in the chat.
Can I ask a question, Wenjie? Wenjie, very nice talk.
Of course.
So I think the key identification assumption is the mean exchangeability assumption, which seems to be testable, right? Because and then the implication is that the assumption can be written as in terms of the observed data distributions. So you checked this assumption for your real data application, whether this assumption is plausible or not?
I think this assumption, you cannot check this assumption because in the RCT data, Y is not observed.
Oh, okay.
Yeah.
Okay. That's right. Yep.
Yeah.
Thank you.